I think we've got quite a few people online, so I'm going to kick off. Good morning, everybody, and welcome to the NDS Grand Round. Today we have two guest speakers from Global Women's Health, and the topic is going to be barriers to obstetric care in rural Africa. Anita Makins is well known to us. She's a consultant obstetrician and gynecologist in this university. She has a master's in women's health, and she also has a PhD in postpartum family planning. For many, many years, over 25 years, she has had experience working with many international organizations, especially Fetal, in developing policies and challenging practices for women's health. She's the director of a new master's in global women's health at Oxford University, which she will be talking about. And currently, she is on sabbatical in Sao Paulo in Brazil. Our second speaker is Alex Cairns, who's also a consultant obstetrician and subspecialty maternal and fetal medicine in Oxford. She is the lead for the Thames Valley Networked Maternal Medicine Services, and she works very closely with two charities in Uganda. She has been visiting Uganda for over 7 years and now has a Ugandan medical registration. She's also formed a link for a partnership between the Thames Valley group of hospitals and Uganda. So welcome to the NDS Grand Round, and Anita, the floor is yours.
Thank you very much, Kakila, for that introduction. So I'll share my screen. Can you see that?
Yeah.
Okay, so myself and Alex are going to talk about barriers to obstetric care. Can't seem to move your... Okay, barriers to obstetric care in rural Africa. Let me just see if I can move that somewhere less important. There, maybe. Okay, so can't seem to my slides for some reason. Yeah. I'm just going to try stop sharing and sharing again because I can't seem to move the slides. Let's see again. Sorry about this. Okay, there we go. Now I can move them. Right, so just a short introduction about sort of obstetric care in low middle income countries, but just actually talking generally, if we think globally, every day about 700 women die from preventable causes related to pregnancy and childbirth, and that's the equivalent of one A380 Airbus falling out of the sky every single day, and that does not get reported in newspapers or anything. It's just a daily occurrence. 95% of all maternal deaths occur in developing countries, and it's highest amongst the rural poor, and the vast majority are completely preventable. I always like to tell the story of this little boy. He's called Abu Bakr, and I met him in a hospital in Namuno, which is a town sort of quite inland, quite remote in the north of Mozambique. And he was 9 months old, but when he came to hospital, but he only weighed 3 kilos. And the lady sitting next to him on the bed is his grandmother. So the reason he only weighed 3 kilos at 9 months is because his mother died giving birth to him shortly after she had a postpartum hemorrhage, and she was only 15. So Abu Bakr, unsurprisingly, didn't survive. But the reason I show you this slide and this story is because I just want you to understand or to realize that when a mother dies, it's not really about just that individual life. It's about the impact it has on her children. So in this case, Abu Bakr, and other children that she may have. Their chances of survival are much reduced. You've probably seen these maps before. So here I'm altering the map looking at maternal mortality, and you can see how overrepresented Africa is and how overrepresented Asia is. And then if we do the same for stillbirths, you can see the same pattern. So again, it's not just about the mother dying, it's about that baby that's being born sometimes stillbirth or dying afterwards, and the children that she looks after as well. So initially, when we had the Millennium Development Goals, we actually saw enormous progress in reducing maternal mortality. So between 1990 and 2015, maternal health had its own Millennium Development Goal. So out of 8, we were Millennium Development Goal 5, and maternal mortality dropped by 44%. And then when we moved to the SDGs, sadly, so I've listed them all there and highlighted the ones that are related to women's health, actually more broadly. And we are a small part of Goal 3, which is the health SDG, and then Goal 5 is achieving gender equality and empowering all women and girls. So the result of that was that the investment in women's health decreased. And as part of that, we've had now a stagnation of improvement of maternal mortality rates, and even an increase in some countries. So on the right, we've got a graph showing 3 countries where things have improved. To note, Ethiopia particularly, maternal mortality ratios there have dropped quite dramatically, and it's really interesting to see what amazing progress they've made and how they've turned that around. But then if we look on the left here, you can see countries where maternal mortality is on the rise. So this period is looking at 2010 to 2020. And you can see many of the South American countries, maternal mortality ratios have increased, and in particular, one country there, which is you'd think would be a surprising change, is the USA. So maternal mortality ratios in the States are on the rise. And it's difficult really to do a talk about maternal health without mentioning Mr. Trump's Make America Great agenda, because it's had such an impact globally in sexual and reproductive health and rights. So Donald Trump's government dismantled USAID, terminating more than 80% of its contracts and grants overnight. And the issue really was not only the termination of the contracts, but also the fact that it literally happened overnight. So there was no chance for any reorganization or looking for other funds or ensuring sustainability in those projects that were going to shut down. USA globally provided 40% of all family planning. And so you can imagine that from one day to the next, women who previously accessed contraception could no longer access it, and the impact that is having in terms of the number of unplanned pregnancies. Donald Trump's presidency have defunded UNFPA, WHO, UN Women, and UNAIDS. And there's been a termination of funding for the demographic health surveys. Now that's an absolute disaster. Many of you, I'm sure, know what the DHS surveys are, but they basically produce any data that's been used for years now, looking at tracking maternal, child, sexual, reproductive health, infectious diseases, malnutrition, water and sanitation outcomes. So we're literally diving into an era of darkness in terms of really knowing what's going on in many low middle income countries. His government also created the Geneva Consensus Declaration on Promoting Women's Health and Strengthening the Family. And this has been very, and the title of it sounds very grandiose and so on, but it's basically created by his government. It was created in 2020, and it's used as a bargaining tool for aid. So either if you sign up to this declaration, then you may or may not receive aid in one way or another. So it isn't a consensus amongst countries at all. So just moving on a little bit. So when we think about pregnant women dying, why do they die? And it's difficult again to talk about this without mentioning two social scientists called Thaddeus and Main, and their paper that they published in 1994. It was called Too Far to Walk, and it was describing really the journey that a woman goes through, or a woman went through, in order to access health during labour. And they divided the issues that arose into three categories. So firstly, delay in seeking care, secondly, the delay in accessing care, and thirdly, the delay in receiving care. And so when we move forward in our talks, we're going to be using these three delay models. So delay in seeking care is once the lady's decided she wants to go to that the lady actually decides she wants to go to hospital, or her family, her relatives, whoever's looking after her. The second delay is that they've made that decision, and it's actually the delay in arriving in the place of care. And then the third delay is once she's in the hospital, does she actually receive the care she needs in a timely fashion? So we're going to talk about Uganda and Mozambique. I'm going to switch those two round because I'm sharing slides, so it'll just make it easier. So I'll start off just talking about Mozambique. So for those of you that don't know Mozambique, so these are statistics from 2023. So it's pretty low down on the UNDP Human Development Index, 182 out of 193 countries. It has an illiteracy rate in men of 27%, and as in many countries down that end of the index, it's the illiteracy rate in women is much higher at 55%. Very little access to safe water, so only 51% of the population, and a staggering 47% are aged 0 to 14. So the median age of the country is 16.4. So that means that you've got half of the population as a dependent population, so population that's not working, it's their children. And then just for interest, about 56% of the population are Christian, 26% have traditional beliefs, and 18% are Muslim. And if we look at the section reproductive health stats, you can see total fertility there of 49 births per woman. That means that your average woman in Mozambique will have at least 4 pregnancies, but closer to 5 in her lifetime. Sorry, not pregnancies, births, actually. So she'll have probably more pregnancies than that. The adolescent birth rate's 148 per 1,000 women aged 15 to 19. So out of 1,000 women of that age group in Mozambique, 148 of them will have been pregnant or will be pregnant. And then if we look at young women between 20 and 24, 52.9% would have been married before the age of 18. And the maternal mortality ratio per live births is 289 per 100,000 live births. So that's an average for the whole country. So in Cabo Delgado, which is a northern province, which is the place that I'm referring to, it is close to 800 per 100,000. So a map of Mozambique, so a small country in East Africa, romantically called the window to the Indian Ocean, because it's got a beautiful coastline looking over the Indian Ocean. So Cabo Delgado is the most northern province, and Chiuri, the town which I'm mainly referring to, has a population of 283,297. So when I lived and worked there for 5 years and have continued very much involved in trying to improve women's health there. When I first arrived, I didn't really understand why the health centres were so empty, because I knew, of the maternal mortality ratio being so high, and so I expected to be seeing all of this morbidity and mortality in the health centres, and the health centres actually were quite empty. So my thinking was the most likely these things were happening in the community, and so the first thing we did was a big study. So it was a mixed method study looking at maternal health practices in Mozambique, trying to understand what were the barriers that women were facing to accessing the services. So we did a cross-sectional survey, and we also did seven focus group discussions. And we had a random representative sample of 730 people, half of which were women and half of which were men. So the inclusion criteria were women who had been pregnant in the last 2 years, and partners of women who had been pregnant in the last 2 years. And then the statistics we used, so we had a general linear mixed model to fit the probability of having cultural beliefs, which particular cultural belief, which I'll explain, and the differences in proportions were determined using Fisher exact tests. So as you can see there, this is just to show you that some of the villages that were selected randomly were extremely hard to get to. So you can see there having to get using a 4-wheel drive with motorbikes on the back. Then you went as far as you could, then getting on the motorbikes, going as far as you could, and then accessing it on foot as well. Women were interviewed by women. This is very important in the Makua culture, especially when talking about sensitive subjects like sexual reproductive health and rights, and men interviewed by men. So just a quick summary of the results. So 35% of people that were interviewed had no formal education, and 48% had primary schooling only. 37% reported that they'd had at least one stillbirth. So that, in terms of maternal health sort of stats, is really high. And 45% reported the death of a child, of which nearly 40% were neonatal, so a death within the first 28 days after birth. Maternal death and neonatal death are very much related. So if you have high maternal mortality ratios, you usually have high neonatal death rates too. 87% of interviewees knew of a maternal death occurring in their village. So that's enormous. If you think about, my 20, whatever it is, maybe 25 years of obstetrics and gynecology, of which, I don't know, maybe 15 years are purely in the UK. I've seen two maternal deaths, where I've been involved in hospitals I've worked in. Whereas here women are saying that, close to 90% knew about a maternal death. And this was more likely reported. So those living more than 20 kilometres from a health centre were 3 times more likely to report a maternal death. So I wanted to talk to you, thinking back to those 3 delays in terms of the first delay, because that was one of the things that we asked questions about. So it was specific to a cultural belief, which had been kind of explained to me by one of the midwives, but I hadn't quite understood, but it became very clear in this survey. So 68% of women knew how a baby, or women and men, know how a baby is formed in the mother's womb, but 75% believe that the woman has to continue having unprotected intercourse in order that that baby can continue to grow. So almost like it's important in order that the pregnancy develops. 56% believe that the pregnancy can therefore have multiple fathers if the lady has had extramarital relations or relationships with more than one man. And this was known as the gravidez juntada, sort of the conjoined or joined up pregnancy. And 40% believe that if the labour was too long, it had an unfavourable outcome, such as a neonatal or maternal death. It was due to the fact that the woman had extramarital relationships during the pregnancy, and that only confession would revert the process. So that obviously has huge implications with the first delay and the actual decision making for going to hospital. And this was an extract from an interview with one of the community leaders. A mother before giving birth must be accompanied by one of the husband's family members. In case there is delay in giving birth, she must pronounce who she has had sexual relations with during the pregnancy, and if she confirms shortly after birth, the husband can submit a complaint to the tribunal, and if the case is approved, the charge is between 1,500 and 2,000 michikais. So not only, is the woman subject to obstructed labour, but then if she makes it through alive, she also has to pay a fine at the end of it. So quite extraordinary. And then we looked at who held this belief. So my automatic thoughts were that this would be something that men were imposing on women, but actually when we looked at the distribution of people who've answered yes to these questions, actually it was much more less common in men. So odds ratio, you can see there 0.22 of having heard of the gravidez juntada, 0.55 of believing in the gravidez juntada, blaming a woman for protracted labour, 0.22, blaming the woman for neonatal death, 0.28, and blaming the woman for maternal death, 0.59 odds ratio. So much less common in men. So it's a belief that was mainly perpetuated by women, and there was a link with the level of education, you can see on the right hand side of the table, but not all the way through. So seemed to be very much something belief held by women. So, and then looking at the second delay, so mode of transport, we also asked questions about that. 50.3 reported that the birth was at home, and 67% said that was the case because of transport. And you can see there that 81% said they went to hospital on foot, 10% used a bicycle, 6% motorbike, 2% bicycle ambulance, which I'll mention later, and 1% other, which would be, a proper motorized, like a car. So in conclusion, that survey demonstrated that both the first and the second delay were hugely significant for women in that part of Mozambique. And so I'll just mention the third delay briefly as well. I thought the best way to illustrate this was just to tell you about our maternal deaths audit. So it's what we call MPDSR, sort of globally maternal and perinatal death surveillance and response. So these were audits which were done monthly in our hospital. So we've got a case here. So this is directly taken out of these cases that were discussed monthly. So this lady presented at a health centre called Namojelia, which is quite remote, at 11:30 at night. 27-year-old lady, G5P3, so 3 normal births before. She was 40 weeks pregnant. She was contracting. The story was that she'd been contracting for 24 hours at home. She arrived dehydrated, pale, blood pressure 80/60, heart rate 100 beats per minute, temperature 36, Simpson's fundal height 33, which is quite reduced. She had no contractions. The fetal heart was absent, and they thought the midwife thought she could palpate fetal parts per abdomen. Vaginal examination, she was 10 centimeters dilated, a very high presenting part, thought to be cephalic, and so the diagnosis was a ruptured uterus. And then the rest of the recordings and the lady's notes are really a very harrowing, sad description of this lady being monitored to her death. So at midnight, she records her blood pressure is 90/60. At 1 o'clock in the morning, she manages to speak to the head doctor for the district, and he suggests to give her IV fluids and calls for the ambulance to go out and fetch her. So this is from the central town of Shiuri out to Namojelia, which is usually about a 2-hour drive. The blood pressure is 130. You can see going through, although I won't go all the way through it, but from 1:30 in the morning all the way through to 4 a.m. she records her blood pressure half hourly dropping, and her pulse gone from being tachycardic to bradycardic, and at 4 in the morning she can't actually feel a pulse. At 5:30 she records her death, declared as a maternal death, and the ambulance arrives at 6:30 in the morning. So, and this was quite a common scenario. So this is an example of a third delay because she did seek help. She was in a health centre. It wasn't the health centre that could deal with the ruptured uterus, because it was a basic emergency obstetric and neonatal care centre rather than a comprehensive, so one that would offer blood and the chance of surgery. But nevertheless, she was within the system, and therefore she, this is part of the third delay. So then the question is, on a sort of happier note, so what did we do about all these problems that we then found out about? So with the first delay, we started these open forums to discuss the local beliefs, and we called it terraço aberto, so the open terrace, and they were very much women's groups and managed by women. We worked together with a grassroots organisation called Wiwanana, and that was very successful. And we also tried to lobby at government level, that there was a need for a multi-sectorial approach in order to improve women's health. That it wasn't just about the Ministry of Health, but also Ministry of Education and so on. Engaging with traditional birth attendants, so these little ladies, enormously important, hugely respected in the villages because they looked after pregnant women and their births, and so making sure they are on board and participating in caring for women through the formal system. And you can see there, this is one of the health centres. I asked the workers to line up so I could take a photo. And so the people in white are the women or men also who actually, paid by the government to work in the health centre. So either a midwife or the técnicos of enfermagem. So they're the nurses, the trained nurses, and everyone else that's not dressed in white is not paid by the government, but nevertheless works in the health centre. And so these are community members, either traditional birth attendants or community health workers. And it's very important. This health centre in particular worked very well because they were a team and they worked well with their community. Again, with the second delay, mother waiting homes, you may have heard of these. So these are small houses that are built next to the health centre where women, when they reach 36, 37 weeks pregnancy, can actually go and stay, so that they're right next to the health centre, so there isn't the issue of transport when they go into labour. Bicycle ambulance, I mentioned. So again, partnering with Wiwanana, the grassroots organisation, we supplied bicycle ambulance to the village, and there would be one bicycle ambulance driver who would be in charge of bringing the ladies. And since then, we've upgraded it to the Oka taxi, which is a motorised version of the bicycle ambulance. And I'll just play a short video because we're looking for funds at the moment related to this project. More than 800 women die daily from preventable pregnancy-related complications, with 94% of these deaths occurring in lower middle-income countries. One of the key reasons is lack of timely transport to healthcare facilities, especially in rural communities where women often live too far to walk to the nearest hospital. My name is Dr. Anita Makins, and I work for the University of Oxford. But for many years, I worked in rural northern Mozambique, where women face the challenges described. Working in partnership with Solidamed, we hope to change this reality. Oka Taxi's drivers gain a stable income for their families, whilst also committing to respond immediately to any emergency call from pregnant women in the community to get them the help they need. As one local woman described, "My last 2 babies came too fast for me to get to hospital, but this third one was born in hospital thanks to Oka Taxi." We, the women in our village, feel safe knowing we can call Oka Taxi in an emergency. Many of our sisters have died when things went wrong and they couldn't get to hospital in time. Having transported over 1,000 pregnant women in the last 3 years alone, we know this resilient system works and are ready to scale to other rural regions in Mozambique, taking this life-saving service to many more women. So that's again dealing with the second delay, and then lastly with the third delay, so ensuring access to basic emergency obstetric and neonatal care services, so BMOC services that actually work. And so we did a lot of training, multidisciplinary training, looking after pregnant women is definitely the realm of multidisciplinary team. So we made sure that the trainings that we gave, included, for example, the drivers of the ambulance, so that they realized that, if you're asked to come at midnight and you turn up at 6:30 in the morning, that's too late, that there is an urgency about it. We also involved the lab technicians, so they understood the importance of transfusing of blood products and the speed at which blood was needed for women with in obstructed labour or postpartum hemorrhages and so on. We included, so we've got the surgeon on the end on the left there, the midwives, nurses and doctors involved, district health, the main district health doctor as well. And so we would do this practical hands-on training with the team as a whole, obviously highlighting the relevant bits for the different disciplines. We also opened, we did it in 2 health centres, small operating theatre within type 1 health centre, so the basic health centre that normally wouldn't offer surgery. We developed small operating theatres and lab functions in order to provide safe cesarean sections. So these are different ways of improving this sort of third delay. So that's the end of my talk. Alex is going to follow talking about Uganda. I just wanted to mention, Kakila did mention it, but our new MSc in Global Women's Health, that's now open for applications. So there's the email there up on the right, or if you just go on the web, and there's a QR code as well. So it's a 2-year part-time mainly online course. It does have 2 one-week residentials in college in Oxford, but the bulk of it is online, and it's really aimed at people who are working in these circumstances, can't leave it, or other people working globally who want to improve their skills and have greater impact at their workplace. So let me try and unshare my screen, and then I'll get Alex's talk up. Alex, are you there?
I'm here. Yeah, can you hear me?
Yeah, I can. So
Great.
I think I have to start sharing before I open it, even before and then if I share, can you see that? Not yet, hang on. We go. And I think, do you apparently I can give you control. Shall I give you control?
Oh, yeah, let's try.
Okay, give control. Be here, shouldn't you? Yeah, you don't come up. Never mind.
I think I'll just get you to move the slides. We might test the Ugandan Wi-Fi. I'm really sorry if there's some background noise. I'm sitting in a room off the labour ward, so bear with us. So yeah, as Anita said, I'm going to follow on from what she's already said about how we have tackled the 3 delays through our project in Uganda. So if next slide, please. I haven't seen it move. I don't know if anyone else has. Oh, there we go. So yeah, Uganda is a country in the middle of Africa, on the right, absolutely smack on the equator, bordered by Lake Victoria and the capital, and Nairobi, which is the old capital and where the airport is, in the south. And we are based up in Hoima in the western region, so up near the shores of Lake Albert, which is up on the western side. This is a photograph of the Ugandan Viral Institute back in 1950, where my great-grandfather worked, and my father was born. My grandfather worked, sorry, and my father was born. So I had sort of sentimental attachment to Uganda for a little while. And the reason that I ended up working here was completely coincidental. I worked with 2 midwives, one of who's here with me at the moment, in the UK in Wexham Park, and they were already involved with a small charity that they'd established. Coming out regularly, spending quite long periods of time here. And I said to one of them on a night shift, and the rest, as they say, is history. And here we are 8 years on from that. Next slide, please. So yeah, as I said, it's right in the middle of Africa. It has a maternal mortality ratio on this slide of between 100 and 299, and sadly that is still the case. This is quite an old map from 2014, and although the Ugandan MMR has
Alex, the internet connection's not great. I wonder whether if you take your video off, yeah, it might be better.
One of the places where mothers and their babies are dying numbers in and related to pregnancy and child. Yeah. Okay. Yeah. I'll take my video off and see if that works better. Is that better?
Yeah, that's better.
Is that any better? You just try. I'm just going to put it onto my phone. Okay, that's better. Okay, that's fine. Just. I've just moved to my phone in case that works better rather than trying to hotspot my laptop. Is that better?
Oh yeah, that's much better actually. Well done.
Okay, fine. I wondered if that was better. Fine. So next slide, please. So the Ugandan maternal and perinatal mortality figures have dropped. The latest figure from the last DHS that Anita was referring to back in 2022 suggested that the MMR had fallen to 189. And the World Bank estimates suggest that back in 1990 it was 687, and it's now down to 170 in 2023. So there really has been very considerable progress, but as you can see, we're a way off the target of 70 in 100,000 that was from the Sustainable Development Goals. The overall institutional MMR for health facility deliveries is about 82, so that's nearer to the 100 and nearer to the goal of 70. But as you can see, the regional referral hospitals, which inevitably get the most significantly complicated referrals, often very late, have maternal mortality ratios up as high as 500 or even 800. And I would say that the last fortnight in Hoima has certainly reflected that, and they are getting, I think, an increasing number of mothers through the front door before they die, which obviously is the aim, but then the hospitals often are not equipped in terms of either human resource or the equipment necessary to tackle these problems, and that is causing a problem with, as Anita's referred to, the third delay. So although considerable progress has been made at a regional level, I think the government regional referral hospitals are suffering because of some of the other progress. And I guess it's what Anita's said. I think anything that's done to tackle maternal mortality and alongside that perinatal mortality inevitably has to tackle all three delays. If you try and tackle one, then you end up with another causing you problems down the track. Next slide, please. In terms of the comparison of the causes of maternal death, this is comparing the latest data from the UK in 2021 to 23 with the 2022-23 data from Uganda. As you can see in the UK, the half of the pie that's purple is indirect causes of death, so non-obstetric, whereas in Uganda, actually the vast majority of the circle is obstetric, primary obstetric causes. In fact, only 1% up the top, and 1% of others is the non-direct. And then there are some other infections, anemia, malaria, HIV, which do contribute, but the big things are hemorrhage, hypertension and sepsis, along with ectopics and anaesthetics and complications related to abortions. So the distribution of causes of death is significantly different here. Next slide, please. So just coming back to the three delays model, there was a report from the Ministry of Health in Uganda in 2015, which identified exactly the same three delays that were Thaddeus and Main talked about before, these haven't changed. They phrased it slightly differently, but in essence, their health-seeking behaviour, the ability to reach the health service point and receiving adequate health care for the degree of complexity going on when they get there. Next slide, please. I guess these are some of the things that I've observed in my time in Uganda over the years. There are a number of different competing issues which come quite neatly under the headings of the 3 delays. Women understanding the need for care, recognising complications, trust in health facilities, similar to what Anita's talked about. That is a major problem here, not least because women attend hospital and then die. And so the perception from the communities is often that is as a result of going to hospital rather than because of what was going on in the first place. Transport and roads have improved considerably here. There's far better tarmac out into the rural areas, so transfer times have reduced, and that's made a big difference. The wet season, though, does still cause problems. Once you reach a health facility, there are then issues of staff availability, staff skills, medical equipment, cold chain, medications, blood products, theatre space. The lay ward here in Hoima and the Regional Referral Hospital is about the same size as the John Radcliffe, about 8,000 births a year, and it's staffed most days by 3 F1 equivalent doctors, 1 specialist and 1 midwife to run the entire place, with a lot of students, but very, very few trained staff for the number and complexity of what they're dealing with. Next slide, please. It's very clear from years of research that skilled birth attendants and health facility delivery are the really important things in reducing the risk of harm to mother and baby. That has improved across sub-Saharan Africa in recent years, but still falls well below target. The latest reliable data, I think, for Uganda suggests that there's about 64% health facility deliveries. You can look at some research that would tell you it was higher than that, but that's from the national reports, which I think gives a more accurate picture. Next slide, please. It shows the distribution of deliveries across the different health facility levels. So you can see health centre 4s and up. So the health centre 4s, general hospitals, and the large PNFP and referral hospitals would be the facilities delivering CMONCs, so surgical management and blood products, are delivering about 40% of the babies, and then about 60% of the babies are being delivered in the smaller health facilities, the health centre 3s, 2s, and the clinics. This split is not inappropriate. It's important that the work gets distributed with the resource, but one thing that I think is being worked on but needs to improve is risk assessment during the antenatal period, such that mothers who are high risk, either through previous caesareans or gram multiparity, twin pregnancies, placenta previas, breech presentations, the very young mothers and the older mothers are identified appropriately and referred in advance to labour to a higher facility. Next slide, please. So this is just a short overview of how we've tried to tackle these delays, or help tackle these delays, with where we work in the Bunyoro region. There are 8 districts in 1 city. The population's around 3 million. Very fast growing. It rose 100,000 in the last year, and 42% of the population are living in multidimensional poverty. The fertility rate, an average of 5.5 babies per woman, is well above the national mean, and certainly internationally. There are also 2 refugee settlements from the Democratic Republic of Congo and the Sudan, which obviously complicates the picture further. Next slide, please. The charity first set up Runga Maternity Clinic in 2017. And the midwives have been running outreach clinics in this village down on the shore of Lake Albert, with a big refugee population for 3 years since 2014. And the local midwives that we work with and the local village population were very keen that we put in a permanent health facility to provide basic medical care and skilled birth attendants, and also crucially the ability to refer for a higher level of care when needed. And so we put in the clinic. It was initially in a slightly smaller premises. This is our newer premises. It delivers about 20 mothers a month, sees a couple of hundred for antenatal visits, and also provides sort of general outpatient adult and paediatric service, with the ability, if we've got a vehicle that enables the women and other patients to be transferred up to Hoima City in the event that they need care. And in fact, there's now a health centre 4 between Runga and Hoima that takes women for CMONT care. So they have blood transfusion facilities. They now have a surgeon and an anaesthetist, so they can do caesarean sections, and that's only about half an hour by road. So that has made a big difference in terms of these mothers' care. Next slide, please. And we stopped doing the outreaches in Runga because we set up the clinic, and the local midwives identified that they were getting a very high proportion of bad referrals and ruptured uteruses and the like from a village called Kirashesha at the other end of the county. And they were very keen that we got involved with them, and started doing outreach clinics there. So from 2017 through to 2020, we ran 6 to 8 weekly antenatal outreach clinics with often teams of volunteers going out to support them, but funding the Ugandan midwives with whom we work very, very closely to go. And we'd see 120 to 170 women per clinic with antenatal, family planning, some HIV and syphilis screening, the identification of high-risk mothers who we would then take back to town or make arrangements for them to come to be delivered in a higher facility. Next slide, please. After we'd done that, again, the local midwives, that's Grace, who was our previous chief midwife, who very sadly died back in 2019, and Borongo, who's pictured with her, who's our lead midwife here now, were very keen that we got the money together to put in another bigger permanent facility in this village. There was very good support from the local community for us to do that, and we were successful. I still am not entirely sure how in applying to UK Direct when the DFID still existed for a small charities challenge fund grant of £50,000. It was a little bit of a shot in the dark, but you know, in the old way, if you don't aim for the stars, you'll never make it to the moon. And somehow they thought they'd take a chance on this tiny little charity with a turnover of about £23,000 a year. And they gave us the money to put in the permanent facility. It opened in March 2020, so I'll let you imagine the challenge that surrounded that in the pink building at the top right, which was rented premises. We rapidly realised that our landlord was something of a crook, and that was causing some problems, and so we fundraised another £50,000 separately to put in a clinic of our own. The local church with whom we'd worked to do the outreaches gave us the land, and we put in the permanent facility that's still open now. Next slide, please. So the clinic's now running. The picture at the top left is the clinic on Monday this week, and that's the antenatal clinic happening in the antenatal room. We got donated an ultrasound machine from a GP surgery in the UK, which we had shipped out. That's our lay ward, and that's our new vehicle, again, thanks to a very generous donation when our old 1992 Toyota Hilux finally gave up, and we were able to replace it thanks to some very generous donor who wishes to remain anonymous. So the clinic is running 5 years from its inception. It goes from strength to strength, delivers a good number of mothers a month, maybe around 60 or 70 mothers a month, about 700, 800 births a year, and sees many more than that for antenatal, for general paediatric and adult OPD, and that's run absolutely by our Ugandan colleagues who we pay to staff the clinic, and we go and volunteer and periodically troubleshoot and help them with problems that they identify, but it's run by the Ugandans. Next slide, please. This is an overview of the data, saying that over time, particularly Kirashesha has got progressively busier and busier in terms of the antenatal visits. The births went up quite a lot in the first few years and are at a similar level now. One of the challenges is making sure that women deliver with us, even if they've had their antenatal with us. Some of the difference is actually accounted for by the fact that we've recognised that they need to deliver in a higher facility, and so they come to a nearby health centre or up to town to the regional referral hospital. Family planning is something that we've struggled with in the last few years. It's always difficult to keep an eye on everything, but I think we need to refocus on that because the numbers have fallen, particularly in Kirashesha. That's partly a bit of a supply problem. We get our family planning from the government, And so there's been with Trump and all the things Anita's alluded to, that's the funding for that has diminished considerably over recent years. Next slide, please. Our first connection with a hospital is Asia Christian Health Centre 4, which is a not-for-profit NGO hospital in Hoima City, with the ability to do caesarean sections, to give blood transfusions, and they've got a 2-bedded HDU. Because one of the challenges with that facility is because women have to pay to deliver the numbers over recent years with the faltering economy have diminished, and so unfortunately they're rather less busy than they were, which of course then applies greater pressure to the regional referral hospital up the road, which is where I'm sitting now. Next slide, please. So the referral hospital, as I said, delivers 7,000 to 8,000 babies a year, similar to OUH. If you ask me, that's gone up further, feeling how it's been in the last couple of weeks. It has about a 32% section rate at the last count, comparable to ours of 40%. That's much higher than the national average across, but would be consistent with other referral hospitals, because as I said, these facilities will be getting the complexity from everywhere else, and so the proportion of the women that they're seeing in terms of previous scars, multiple pregnancy, placenta previa, that kind of thing is much higher. So that's why that's skewed, even though the national caesarean section rate would be less than 20%. They have 2 theatres with 4 operating tables, 2 in each, usually 2 anaesthetic officers around during the day, 1 for the evening and 1 at night. There are 4 specialists who would cover the gynaecology, postnatal, and then maternity and the labour suite, along with 3 residents and 8 interns, which are like an F1 equivalent. So you can see that the skill mix for a workload like that is really very low. And I think one of the things I've felt over the last 2 or 3 years is that it's important to try to support this end of the referral chain as well, because of course our complex women are with really very complicated medical and obstetric problems, and I think there are huge challenges. I think we work quite closely together. I come fairly regularly. It would be nice to come for longer. But I hope that by just at least building the relationship with the local doctors, that it's more useful than going to different places, although it never feels like quite enough. Next slide, please. At a regional level, locally, there have been efforts made to connect the different health centres with the central regional referral hospital. And actually, Uganda has set up an LMNS project, which is the local maternity and neonatal systems, which is very like the UK system in terms of uniting the spoke facilities with the hub. And so I think that has improved risk assessment, has improved identification of mothers, and actually tackling the second delay of accessing the appropriate level of healthcare has improved as a consequence. I think that has produced a different challenge in the referral hospital, because the workload has increased and the complexity has increased for the same resource. Next slide. The NS has weekly regional meetings for the region, presenting on findings. They coordinate services, staff and resources, including blood products. There's a WhatsApp group which works for sharing resources, information, national campaigns, and also the details of individual referrals, such that the central site is aware of what's coming, and so they can be a little bit more prepared, which I think, having been here when it works, is really hugely helpful. The next slide, please. So one thing we're working on, which is in its infancy, is trying to prospectively in the spoke facilities, so they are referred in advance rather than in an emergency when they've obstructed their labour or ruptured their uterus or bled with their placenta previa, and identify women as green. They're okay to deliver in a non-CMOC smaller health facility. Amber, they need to at least be in a CMOC facility, and red, they really do need to be at the regional referral hospital, and there is a waiting home here, so there's the capacity to bring women up in advance of labour or in advance of their due dates, so that we can look after them here and they can be local. Next slide, please. So finally, I realise this has been quite a rattle through. There has been an increasing number of often very medically complex referrals. The physicians and intensivists in Oxford will know that I've been on the phone to them a considerable amount, asking advice about things that are outside my area of expertise, but unfortunately also outside the expertise available here. There's no real practicing physician. There's no anesthesiologist, just anaesthetic officers who are absolutely excellent at what they do, but slightly more limited in their scope and would self-confessedly say they're not intensivists. ICU, HDU availability, there is a plan to open an ICU here in a building that's been constructed, but there are challenges with resourcing and staffing that are prohibiting it from actually opening and functioning at the moment. And of course, Ugandan IVF. So these are some triplets looking very cheerful who I delivered last week from a 43-year-old primary who had some IVF up in Kampala, and they put 3 embryos back. And whilst she and her baby's an excellent outcome, and we're undoubtedly very lucky, at least one of them is very much going to know that is undoubtedly going to add to the burden of complexity in the coming years. And I really do feel for my colleagues here. Next slide, please. And so just to say thank you very much to my fellow trustees, Ree, who's here with me at the moment, Sophia and Harriet, and to Dr. Bwago, who's the director of the hospital and also an obstetrician, and all of his colleagues here over the years who've made me very welcome, Makins and Murungi, the anaesthetic officers who are old friends of mine and have just taken exceptional care of a very poorly woman in theatre, and I'm always extremely happy to see them. We have our colleagues at ASO, including Gorongo, who runs our clinics with an expert hand for us, and Dr. Hannah and Dr. Mark, Albert and Lillian, who looks after our house and takes care of us and ensures we have some clean clothes to wear and some food to eat. That's the donation link down the bottom if anyone's interested. I'm very happy to share more with anyone else, and those are the references. Thank you so much.